Good morning, all. I am Dr. Abhijeet Shrivastava. So today I am going to talk about tuberculosis, infectious disease in pediatrics. So to Robert Koch, one who discovered tuberculosis. This is the how Mycobacterium tuberculosis looks like. So what's the plan of India to end tuberculosis game? That is that National Tuberculosis Program was first started in 1962 and it was there up to 1997. Then RNTCP started by 1997 and was there up to 2020. Now there is a NTEP launched under National Strategic Plan 2020. Till date, it is going on. So epidemiology is 95% in developing countries, one third of world population affected, 2 billion caseloads, and 8 million new cases annually, 1 million die annually. 98% port of entry is lungs, 8% multi-drug resistance tuberculosis, and some extended drug resistance too. And HIV is like a co-epidemic. Clinical features: clients attending HIV care settings, uh, substance abuse, smokers, comorbidities like those who are suffering from diabetes mellitus, malignancy, on dialysis, on immunosuppressant therapy, healthcare workers, contacts, and past history of tuberculosis, malnourishment, and antenatal care. In social causes, is like prisoners, occupational risk, overcrowding, night shelters, de-addictions, and old age home centers. And so, urban slums, geographically, we talk about urban slums, hard to reach areas, indigenous and tribal population. So, burden of tuberculosis, globally, the incidence is 9.6 million, prevalence is 13 million, and mortality is 1.1 million. In India, it is 2.2 million, almost one fourth, and 2.5 million is the prevalence, and 2.2 lakhs die. So, vision, world TB, free of TB. So, this is about India, like 3.8 million cases, 600 die every day, 800% among youth white, all age 1.6%, 40% under 16 infected, 10.5% of them develop disease, MDR 3%. Taxonomy of mycobacterium, it is like tubercular and non-tubercular. So M tubercular, tuberculosis, Mycobacterium bovis, Mycobacterium africanum, Mycobacterium microti, Mycobacterium candidate. Non-tuberculosis, photochromogens, scotochromogens, non-chromogens, and rapid growers. So it is like microbiology wise, it is a non-spore forming, non-motile, pleomorphic, gram-positive, curved rods, obligate para-aerobes, and facultative intracellular parasite. Two groups, infected asymptomatic, that is called latent TB. Man2 positive, no signs and symptoms. Tubercular disease, clinical, bacteriological, smear and culture, pathological biopsy specimens, and radiological. So, primary childhood, latent tuberculosis, primary complex, progressive primary complex, disseminated tuberculosis, reactivation, tuberculosis extrapulmonary. Secondary adult tuberculosis. So, primary and adult TB, what are the differences? So, no prior immunization, immune sensitization, very strong existing immunity. Disease spreads to regional gland and further disseminates to different organs. Here, localization of the disease to the affected organ. Delayed hypersensitivity develops during the course of disease, hence less tissue destruction. More tissue destruction due to developed hypersensitivity. Subpleural focus develops anywhere in the lung bone focus. Apical region commonly affected due to more oxygen availability, that is Simon focus. Cessation and cavitation less common. Cessation and cavitation more pronounced. Lesions heal by calcification, healing by fibrosis. Pathogenesis. So, adult tuberculous cavity, cough with tussive force, bacilli reach and multiply in alveoli, mostly killed by macrophages. Inactive macrophage carry live bacilli to regional lymph nodes. Lung and node lesions heal by calcification. And susceptible or progressive, primary lung lesion, that is bone focus, like lymph node enlarges, progresses, compress, collapse, consolidation, caseation and rupture, then dissemination. So bronchus or through endotracheal tuberculosis. Blood vessel and disseminated tuberculosis. Pathogenesis, disseminated tuberculosis, lymphohematogenous spread, epices of lungs, Simon focus, brain tuberculous meningitis, liver, kidney, bone and joints, biliary. Varying periods of dormancy, more than 7 years of age, usually adolescents, upper lobe infiltration, Simon focus, caseation and cavitation, pleurisy, pericarditis, tuberculosis. So here we see with time line infection, non-focus, primary complex, healing. 1 to 5 year, progressive, primary complex, disseminated tuberculosis. 5 to 15 years, quiescent metastatic lesions, Simon focus, reactivation tuberculosis. So bacilli land on well ventilated subpleural area of lung. Neutrophils migrate first but could not fight due to resistant bacterial cell wall. Monocytes come for second line defense, engulf the bacteria but could not kill. Form epithelioid cells which are multinucleated germ cells. Third comes T lymphocyte CD4, get sensitized and release cytokines. CD4 release cytokines which activate CD8 cytotoxic cells. CD8 lyse monocyte and release bacteria. Activated macrophages ultimately kill the bacteria. Cell mediated immunity, humoral immunity less role. Lymphocytes recognize mycobacteria, produce lymphokines. Lymphocytes and macrophages attracted to site, and macrophage engulf and kill mycobacteria. Delayed tissue hypersensitivity develops and granuloma form. So this is tubercular granuloma, which is showing lymphocytes, epithelioid cells, and giant multinucleated cells, which is called ganglions. So this is a picture of caseous necrosis. So about latent tuberculosis, asymptomatic, MAN2 positive, chest X-ray normal, no clinical signs, 40% develop symptomatic tuberculosis. Maximum progression in first 2 years of life. Reactivation during adolescence. So clinical features and external markers. So clinical features, fever for more than 2 weeks and cough for more than 2 weeks, malaise, night sweats, malaise, anorexia, and weight loss. External markers, wasting, lanugo hair, long eyelashes, flectanular conjunctivitis, scrophulosderma, sinus ulcers, lupus vulgaris, and tuberculosis. So it is important. I would like to repeat external markers. It is wasting, lanugo hairs, long eyelashes, flectanular conjunctivitis, scrophulosderma, sinus ulcers, lupus vulgaris, and tuberculosis. Other forms of tuberculosis is like those who are non-pulmonary also. So lymphadenopathy, most common extrapulmonary manifestation of tuberculosis. Scrofula, more in Mycobacterium bovis. Firm, non-tender, matted, fixed, also called by atypical Mycobacterium MAN2 positive. And fine needle aspiration cytology is the investigation of choice. Upper respiratory tract, laryngitis, CSOM, pleurisy, and pericarditis. Biliary tuberculosis, choroid tubercles, miliary mottling in X-ray, CNS, tubercular meningitis, tuberculoma, abdominal tuberculosis, TB arthritis, osteomyelitis, renal and genital, which is very, very rare. So this is the pictorial presentation. So here we have a tuberculous lymphadenitis, enlarged lymph node in the cervical area. We can see A, B. They are take. This is a cold abscess. So they are aspirating the cold abscess. Multiple areas of yellowish white cheesy like necrotic area. This is the gross picture. So approach lymph node more than 2 centimeter in one or more site. Matted lymph node, cold abscess plus minus sinus. No. Then 7 days of course of antibiotic and review after 2 weeks. Non-responsive. FNAC. MAT. Acid fast bacillus smear. MGIT pus from lymph node. Discharge from the sinus improves the yield. Yield is smear is 10 to 15%. Culture is 20 to 50%. NAT is 35%. AFP detected on smear. NAT positive and caseous granuloma. treat as a case. If no granuloma, non-caseous granuloma, no FB on smear or NAT, excision biopsy. Often the quality of NAT may be more easily available than cytology. Then one may resort to cytology only in NAT negative cases. So this is the multiple uh, lesions of tuberculosis, tuberculous lymphadenitis, and sinuses. So this is also one scrofulloderma. This is verruca and lupus vulgaris. That is skin tuberculosis. So this is of tuberculosis of middle ear with multiple perforation. So double perforation, chronic painless watery discharge, hearing loss, tympanic membrane perforation and ossicles affected, pale granuloma that does not bleed, tubotympanic disease with facial nerve palsy. Pus will not grow anything, tissue granuloma needed for AFB and HPV, histopathological examination. So this is one of the serious manifestation of tuberculosis. Pott's disease, spinal tuberculosis, common clinical presentation, fever, worse at night, constitutional symptoms, malaise, night sweats and weight loss, back pain and progressive kyphosis of the lower thoracic and lumbar spine, neurological deficits such as difficulty walking, clumsiness, and paraplegia, cold abscess, soft tissue mass around the site of infection, children and younger adults. So this is about kyphosis, the picture. And like first A, you can see as a normal spine, then infection of peridiscal region on cartilage end plate, then infection of intervertebral disc, that is called discitis, and spondylocytis with kyphosis and subligamentous disc abscess. This is Asherman syndrome, uterus, uterine cavity, fallopian tube. So here you can find that scar tissue or adhesions, shrunken uterine cavity. So uterus with Asherman syndrome. Tuberculosis in pregnancy. So what are the complications? One is prematurity. IUGR, increased perinatal mortality, and tuberculosis in newborn care. Contraindication of tuberculosis in newborn care. So we follow detect, treat, and prevent. It is a Rashtriya Swasthya Mission. Detection means we have a new pyramid of tuberculosis diagnostics. Specificity, sensitivity. So sensitivity is like characteristic symptom, tuberculosis skin test, IGRA, conventional radiology, and microbiologic confirmation by UDST. So yield of test and robustness of diagnosis can be improved by better characterization of symptoms and interpretation of radiology. So this is about the protocol. So persistent fever for more than 2 weeks without a known cause, unremitting cough for more than 2 weeks, weight loss of 5% or no weight gain in past 3 months despite adequate nutrition or failure of nutritional rehabilitation in babies with severe acute malnutrition, with or without contact with patient with pulmonary TB in past 2 years. X-ray chest X-ray highly suggestive of tuberculosis, expectorated sputum, gastric aspirate for NTEP, approved NAT for MTB. So NAT positive, microbiological confirmation of TB case, followed by the pathway. NAT negative, so like X-ray chest non-specific shadows, give a course of appropriate antibiotic, skip this step if already received appropriate antibiotic course. Then persistent shadow and symptoms, look for any other site like a significant enlarged peripheral lymph node and test the lymph node aspirate for MTB. Consider repeat NAT from a better quality specimen or alternative specimen like bronchoalveolar lavage or aspirate depending on availability and feasibility. May seek review from a higher center. NAC positive, then go back to microbiological confirmation. NAC negative or X-ray chest normal, check for EPTB, extrapulmonary tuberculosis, needs detailed investigation for TB or an alternative course for the symptoms. May require CECT chest or other investigations depending on symptoms. Consider referral to a higher center for further investigation. No other likely alternate diagnosis. Treat as a clinically diagnosed, probably tuberculosis. So, radiologically, highly suggestive imaging findings, patterns like hilar, mediastinal lymphadenopathy, chronic fibrocavitary disease, and miliary pattern. Patterns like consolidations, non-homogeneous opacity, ground glassing, thin-walled cavities. So here you can see in first right paratracheal and hilar node enlargement. Parenchymal lesion is seen on the right lower zone with the associated right paratracheal node enlargement. In some cases, there might be a consolidation with a contralateral nodal enlargement as shown, but it can sometimes be without any discernible node on frontal view. So a lymph node mass with airway compression with radiological suggestion of partial obstruction with right-sided hyperinflation. The X-ray shows a lymph node shadow in aorta pulmonary video with an accompanying area of consolidation. Pulmonary primary complex with the compression of lower third of trachea and right airway. Miliary shadows in both lung fields are highly suggestive of tuberculosis in our setup. Extensive disease with multiple areas of breakdown, more on left side, fibrocavitary pneumonia. So this is cavitary pneumonia. This is also cavitary pneumonia. This is a lateral view. This is a PA view. How do we access the respiratory specimen when the sputum is not brought up spontaneously? So gastric lavage or gastric aspirate is option and induced sputum is the second option. Preferably after overnight fasting, we should collect. Can be done in ambulatory setting with some loss of yield. Invasive, needs better trained staff. Induced sputum, fasting not needed. Ambulatory setting, less invasive, can be learned easily by paramedics. Requires good infection control measure to decrease risk of transmission to provider as it provokes cough. New rapid molecular test for tuberculosis. So TrueNet MTB RIF DX developed by Indian firm Molecular Biology Diagnostic Private Limited Goa. Battery operated two-step testing, not fully automated, may get centrifuging of samples like gastric aspirate, requires two steps process, DNA extraction and then addition to the chip. Expert MTB RIF Ultra, new generation nested PCR cartridge used in the same equipment. Ultra has lower detection limit, 16 bacilli per ml sputum as compared to 131 per ml for expert MTB RIF. Especially useful for possibacillary disease in children. HIV TB co-infection. Ultra may replace expert in near future. This is about MAN2. Basis delayed cellular hypersensitivity. 0.1 ml intradermal. 5 TU of PPD twin AT strain. Read after 48 to 72 hours. Early detection or early reaction not positive. Delayed reaction is positive. The false positive, it is non-tubercular mycobacterium or in BCG up to 5 years, less than 10 ml. False negative is energy, infant, malnutrition, suppressed immunity, vaccine, measles, MMR, measles infection, miliary tuberculosis, technical error. Positive reaction, contact history, symptoms of pulmonary tuberculosis, HIV, immunocompromised, immunosuppression, high prevalence area, low prevalence area, recent man to conversion, serial man to. So they have their different criteria for positivity and negativity. So gastric aspirate, 3 consecutive morning samples is needed. Bronchoscopy can be done. Negative culture and smear do not rule out tuberculosis. Ziehl-Neelsen staining, it is the age-old method to identify tuberculosis. So it is heat fixed smear with carbamazepine, steam for 5 minutes, rinse, add 3% acid alcohol, 5 minutes wait, rinse, methyl blue added again, 1 minute, rinse, dry, and bright red purple bacilli will be seen. Another method, so auromin, rhodamin fluorescent stain requires a fluorescent microscope. This is a Lewin Jensen medium. This is like interferon released other test by T cells towards empty antigens, spot, PCR, 30% more with HIV. So this is an approach for tubercular lymph node, what we have already discussed. Treatment part as per the guidelines. So that is also been classified as cured, treatment completed, treatment success, failure, failure with this. Thank you. Hello. Hello. Good afternoon, ma'am. ಹಿಂದಿರಲ್ಲ ಹಾ ಇಲ್ಲ ಮೇಡಮ್ ಥ್ಯಾಂಕ್ ನೋ ಮೇಡಮ್ ಐ ಆಮ್ ವೆರಿ ಮಚ್ ಬಿಸಿ ಥ್ಯಾಂಕ್ ಯು